So thanks, Mel, and thanks, Jen, for the invitation. And as was mentioned, this is going to be about Dale's talk, who's the third speaker of the panel, is really going to focus on the intensive care for potential organ donation. I'm going to start with a slightly broader lens and look at all of pre-mortem interventions and really frame the ethics for preserving donation opportunities. My disclosures: I have no conflicts with for-profit entities. I'm a paid consultant with Transplant Québec, researcher in the field, and as Mel mentioned, a full-time pediatric intensivist. One last disclosure that you should all know is that Jennifer, Dan, Amanda, and I recently had this paper accepted. It's in press. But I can say the reason I listed as a disclosure is that listening to someone talk about their scoping review is a bit like looking at someone else's vacation photos. You know there's going to be some good stuff in there, but it might take a little while. So I apologize ahead of time for that. So this is the definition we're going to be using for pre-mortem interventions, both in this talk and what we used in the manuscript. These are actions intended either to enhance planned donations or preserve the opportunity of donation. This figure comes from a publication from Samer Zavalkov et al., really about organ donor identification, but it gives a good overview of the entire donation process. And we can look at where PMIs, or pre-mortem interventions, will come into play. And the first point is here, very early, after the injury, when there is a severe injury, often a severe brain injury, that is a direct threat to the patient's life. And there's a question as to whether or not initiation of therapy would be appropriate to save the person's life or even potentially beneficial. And that initiation of those therapies might be influenced by the possibility of preserving organ donation rather than saving the patient's life. The other place where they can be applied, and this is in a donation after circulatory death. I know most of the people on this call are very familiar with the distinction between donation after brain death versus circulatory death, but this is after circulatory death where there's been a withdrawal of life-sustaining therapies, and they are often given in the minutes to hours before the determination of death to preserve the function of the organ after transplantation. So we're going to give some examples of that. There are some gray zones, some things that we did not address in the paper or in this talk. So for example, uncontrolled DCD, which is where a patient has an unexpected cardiac arrest out of the hospital, and measures are taken even before arrival in the hospital, including death determination and reinitiation of CPR. We specifically did not look at issues around uncontrolled DCD for this. And also, sometimes there's a gray zone where you have a patient who there is general consensus is heading towards a neurologic determination of death, but has not been formally determined. So those are all the application of measures to enhance donation after determination of death are usually referred to as donor management. We didn't look at those issues, and we didn't look at those issues even if they were applied prior to the determination of death, which is not the moment where they generally should be applied. So if we're going to talk about enhancing DCD, which is a big section or a big group within the broader umbrella of PMIs, well, here are just a few examples. So one that is often discussed is heparin, which is an anticoagulant, and a DCD process after withdrawal of life-sustaining therapy. There's going to be a period where the blood pressure or the perfusion of the organs is going to decrease. That can lead to stasis of blood within the organs and potentially clots. And so heparin as an anticoagulant is something that is given specifically to avoid biliary complications after a liver transplant. Another example could be cannulation. This is something which is routinely done after death, and in some areas, some programs in the States, some in various areas of Europe, has been done. You can see there's a surgical incision that is made in the groin, and then cannula are inserted into the femoral arteries and veins to allow flush of preserving fluids, or sometimes even normothermic regional perfusion, where the organs are perfused with oxygenated blood after the determination of death. So it's another example of interventions, relatively invasive, that are sometimes proposed before the determination of death. Now, not all of these PMIs have these type of medical risks associated with them. So for example, one thing that could be considered a PMI is just transfer of the patient. In most centers, prior to withdrawal of life-sustaining therapies, the patient is going to be transferred either directly into the operating room or near the operating room. That's not universal. Some centers do the withdrawal in the ICU, but wherever the withdrawal is done, the family is going to be escorted away from the bedside immediately after the determination of death, because those organs need to be recovered quickly. So that's an alteration of end-of-life care that it could certainly be seen as a PMI. And the end-of-life care is going to be more medicalized than it normally would be in a withdrawal setting without donation. So for example, maintenance or insertion of an arterial line shown here that is going to be used to precisely determine the moment of death is another way that care is altered when donation enters end-of-life care. Now, for the category of PMIs that are for preserving donation opportunities, and that includes both initiation and maintenance, often we're talking about mechanical ventilation. And we're talking about it in that setting that I already mentioned. A patient arrives in an emergency department, often an emergency department away from an organ recovery center with a severe brain injury. And the question is, do we intubate this patient with at least one of the goals being to preserve donation opportunities, and what are the ethics around that? But on a more subtle level, all DCD requires maintenance of some level of life-sustaining therapy after the decision to withdraw, because the patient is going to remain on the ventilator throughout the period where organ donation logistics are organized. So those are the two main categories, and some examples of PMIs that fall within those two categories. But if you look at the literature review that we performed, these are just a brief overview of the methods. It was a scoping review of ethical aspects of PMIs. So inclusion and exclusion criteria are listed here. Were peer-reviewed journal article or book chapters that looked at ethics, law, and policy of deceased organ donation. Living and tissue donation were excluded. Out were most of the gray literature, because there was a rich body of peer-reviewed literature, as well as articles that focused exclusively on biomedical efficacy without linkages to the ethics, law, or policy. Post-mortem and animal research were excluded. We discovered approximately 5,400 references, of which nearly 200 were retained and coded. The group of 4 authors, there were 2 clinicians and 2 non-clinicians, and we double coded the articles using qualitative thematic analysis in groups of 1 clinician, 1 non-clinician. When we developed codes based on what we on the full text extraction, you can see these are the themes on the left and the specific codes on the right. There were subcodes to those, which would have been too complex to include on this slide, which is already busy. Apologize for that. But you can see here that there were donor interest, family interest, healthcare professional, et cetera, et cetera. We're going to focus mainly on donor interest and consent principles for this talk, which were by far the most commonly mentioned issues. Also, just a note that as I said, an exclusion criteria was that we didn't look at the efficacy of many of the interventions around enhancing DCD. And so we've already mentioned heparin, that's an example that there's really poorly documented medical risk and benefit to heparin and most of the other procedures that are mentioned as these enhancing pre-mortem interventions, which is one of the reasons there's substantial practice variability across the world. The other reason being that the legislative and policy framework surrounding them varies quite a bit, as Thaddeus is going to detail. So I just wanted to make sure everybody understands that since there is a lack of evidence for how well these procedures work and what risks they pose, well, there is a lot of speculation, especially in the ethical literature, that either exaggerates or minimizes those risks. Frankly, according to the desires of the argument being made. But at any rate, if we're going to look at what are the risks that are at least possible for donors, because that was one of the major topics. And the first thing that was always discussed were potential physical harms. Some of the physical harms are almost certain to be part of the procedure, but cause relatively low harm. For example, blood draws. All donors are going to have blood draws for haplotype matching. They're going to, and an organ function to evaluate eligibility. It's a guaranteed harm, but a relatively small one. The reason heparin is so often discussed is because many DCD donors have CT scans that look something like this, where there is a significant intracranial bleed. The white on that CT scan represents blood in the brain. And if we're giving heparin as an anticoagulant, which is going to prevent clots in the organs that might be transplanted, well, there's at least a theoretical risk that that same heparin would increase the size of that bleed and might actually become the proximal cause of death, which would be an instance of causing death to facilitate donation and a violation of the dead donor rule, which, while not ever having been documented as happening, is a frequently cited risk. Another risk that merits specific interest is the persistent vegetative state. And the often discussed issue here is that if you initiate therapies in the emergency department with a severely brain injured patient, you might stabilize that patient enough that they survive through the acute phase of their injury. And then when withdrawal happens, say days or weeks later, they might survive in a state where they don't die rapidly, but they're instead in a deep, unresponsive coma, often referred to as a persistent vegetative state. At least one author referred to this as the rub, which he described as the risk of unacceptable badness in this 2005 bioethics paper. And in reading around this, I've found that that's actually a term that is relatively often used in the ethical literature, as well as Dungeons and Dragons, for all the dungeon masters out there. So there's that. And then there was a lot of discussion of non-physical harms as well. A lot of discussion around Immanuel Kant and his principles of not using people as a means to an end, but always treating them as an end in and of themselves. And so the concern here is being that if we apply pre-mortem interventions and expose people to risks, they are being used as an instrument to help other peoples receive a transplant. And so Kantian ethics were widely discussed in the concept and the construct of PMI ethics. Other non-physical harms included violation of bodily integrity or donation against a deeply held but non-expressed desire not to donate. Now, there were donor interests that were benefits that were often discussed as well. Now, it's clear that none of these benefits were physical. There were no physical benefits that could happen. All of these interventions were done for the benefit of donation, not to treat the underlying physical illness that the donor had. There was potential, however, for benefits in end-of-life care, with the idea being that in general, end-of-life care can be better administered in an ICU setting in a much more controlled environment than, say, in the chaos that routinely happens in an emergency department. But by far, the most commonly discussed benefit to the donor is fulfillment of desire to donate. We're going to dive into that a little bit. But before we do, the other codes that are worth mentioning that came up pretty frequently are family and societal interest. Family motivations and family benefits that could support donation include a lot of things, like the idea that the families might have a decrease in the intensity of their grief after the loss of their loved ones. Although there were some authors who pointed to caution in overemphasizing that concept, because so you could imagine a family or parents of a young child and their desire to make sure that a part of that child lives on with someone else could lead them to accept risks on the part of their child that were not necessarily in that child's best interest. So some caution there. Benefits to society were clearly stated. I mean, the fewer people we have in these dialysis chairs, obviously for the transplant recipient, it's a clear benefit, but even for society, getting those people back as full participatory members of society is of an interest to everyone. However, there was at least potential described as harms to society, the most important being erosion of public trust. If the general public were to think that we are more interested in treating a person who arrives as a vessel to provide organs to someone else, they might put less effort into saving their lives. And that could lead to an erosion in trust, not only in the healthcare system in general, but very specifically in the donation system, and could perversely lead to a decrease in donation activity. So if we're going to look at a balance of how we would consider PMIs, well, on the left-hand side, if we were going to think about things that would support limiting PMIs, there's a potential physical and non-physical harms. There are at least theoretical familial and societal harms. On the allow side, you have the familial and societal benefits, but you need to include post-mortem non-physical benefits. Really what we're talking about is that fulfillment of a desire to donate. And for a lot of the clinicians on the call, I imagine the idea of post-mortem benefit is not something that we are accustomed to thinking about a lot. But in society in general, it's something we pay quite a bit of attention to. And so the most obvious example being how we treat estates after our death. I'm sure most people on the call have a will and are very interested in what happens to our belongings, be they monetary or non-monetary assets. And there's also the idea, a lot of people put a lot of effort into maintaining the idea of an altruistic legacy that will be honored even after our death. Once again, I'm sure we could all reflect on how many of us work in buildings that are named after philanthropic donations. And anybody who's been following this guy over the last 15 or 20 years knows how much effort he's put into making sure that he will be remembered altruistically. So in terms of, once again, back to this balance, if we do not have post-mortem benefits as a consideration, well, there's really, the pendulum would swing toward limiting and maybe even eliminating PMIs. But if we include post-mortem benefits, then the balance becomes a lot more equal and would allow for PMIs in certain circumstances. And that is reflected in a general evolution in the ethics literature. This is an article from 1992, which strongly criticized the Exeter Protocol, which was a specific elective ventilation protocol in the UK in the late 80s, early 90s. And the idea that consideration of post-mortem benefits should not only not be considered, but it should be viewed with suspicion as almost a bad faith effort put forward by people who want more organs. Now, that in contrast to this 2013 article from some Spanish colleagues who argue that not only should we consider ventilation of the severely brain injured, but it's almost a moral duty to preserve their opportunities to donate and provide better end-of-life care. So those are the ideas of risks and benefits. We also need to consider, importantly, consent, which was the other key issue that emerged from the literature, with near universal acceptance that PMIs require independent informed consent being as normally constructed, independent being the idea that this consent needs to be independent of the general consent for donation, since consent for donation generally applies to removal of organs after the determination of death, whereas all of these interventions happen prior to death. The tricky thing is that this consent will almost always be from surrogate decision makers, and these surrogate decision makers will almost never know what the patient's intent was regarding PMIs. I think the exception, I'm sure some of us on this call have talked about it with our loved ones. I know I certainly have with my wife. I've made sure that if she does not consent for any PMI that would facilitate donation, I will haunt her for the rest of her days. I've given some thought to the form. But the question really is, when the SDM is considering consent or not, it really comes to how far can we stretch that fulfillment of the desire to donate when we're weighing the risks and benefits. And some of the factors that modulate that are how strongly the person may or may not have expressed their intent to donate, what the impact of presumed consent models may be. Does that diminish the bar for giving consent for these issues? How to deal with the PMIs that have little evidence to support their risk or benefit, and how do we deal with patients who were never competent? Obviously, we're talking about children here, but it could also be people who have intellectual disability and never gave their consent. Other issues, which I'm just going to run through rapidly to prime the pump for our discussions: utilization of scarce resources, using ICU beds for people who have a very limited prognosis for themselves, conflicts of interest if you have a patient who is both waiting for an organ and a potential donor in the same unit, and the inherent tension between an advance directive where a patient does not want to be intubated in the case of a severe brain injury versus they want to be a donor, which will require an intubation. That's an inherent tension that needs to be dealt with. So despite this controversy, I want to make sure that it is emphasized that pre-mortem interventions are widely accepted as long as they have good ethical guidelines around them. These are just 4 examples, and there are many, many more that you could look at of professional or regulatory body recommendations that recommend that PMIs are acceptable as long as they have good ethical oversight. And so some basic questions we always need to ask ourselves: do we really need this PMI when we are asking for it? Are we sure that it is that the efficacy justifies it? And have we minimized the risk? Have we really worked hard to make sure that risk is minimized however possible? Do we know the person's intent? And do we have valid consent that is independent of general consent for donation? So sorry, I went a little bit over time. That's my email. And here's one last vacation photo. So I will go ahead and stop my share and allow Thaddeus, who's going to talk to us a bit more about the laws around these in some specific cases.
All right, thank you, Matt. So.
You want me to introduce you, Thaddeus?
Oh, sorry, go ahead.
You're jumping in. That's fine. So it's our pleasure to welcome you. And I know you're ready. So this is great. And you're going to talk about non-therapeutic intensive care for dead and almost dead potential organ donor. When must clinician get consent? And you're professor of law at the Hamline School of Law from the States. Welcome, Thaddeus.
Thank you. All right, so permissible pre-mortem non-therapeutic interventions. So let's say you have someone, they have signed up to be an organ donor. What exactly is it that they understand that they've done there? Well, clearly, as Matt said, they understand that they've authorized clinicians to remove their organs after death. But what else has she authorized? What about non-therapeutic interventions? Right? Things that Matt mentioned: mechanical ventilation, CPR, vasopressors, hormonal therapy. Right? These are things that are not for the patient, they're only for the organ. And, you know, as Matt said, we sometimes call this organ protection therapy, donor optimization procedures, donor management. Dr. Gardiner, who's going to speak next, has a term: intensive care for organ preservation. We deploy non-therapeutic interventions both for patients that have been determined dead on neurological criteria and circulatory criteria, and we administer them both when the individual is still alive and after the determination of death. When you administer non-therapeutic interventions after the determination of death, that's relatively uncomplicated legally, because once someone is determined dead, they're not a patient. And if you're not a patient, we don't owe them treatment duties, right? Those are turned off when the patient dies. And so at that point, the person is only a donor, not a patient, right? So clinicians can focus. They have a single target, which is only on organ optimization at that point. But when you administer non-therapeutic interventions when the individual is still alive, before the determination of death, that's more complicated. When the individual is still alive, they're still a patient. And when they're still a patient, we still owe them treatment duties. So the problem is this: you have one patient, you have one individual in the bed, but she's playing 2 different roles, right? She is both donor and a prospective donor and patient. And the rules that apply to donor and patient are different and sometimes pull in opposite directions. So in this presentation, I'm going to focus on the non-therapeutic interventions administered before the determination of death, right? And we could call these pre-mortem non-therapeutic interventions. So here's my roadmap, just in 4 parts. What are some legal challenges? How can we get around those with first-person consent, with surrogate consent? And then what are some ways forward? So some legal challenges, right? And here are just three of them. One is there's conflict sometimes. So again, let's say you have someone, they've signed up to be a donor, but they also have an advance directive, right? So that means this person has at least two wishes. One is a wish to be a donor, but the other is a wish about the type of end-of-life treatment that they want or don't want. And those two wishes can conflict, right? So for example, right, they might have an end-of-life wish not to have CPR, not to have mechanical ventilation, but that may be necessary in order to be a successful donor, right? Which wish prevails when they contradict each other? That's often unclear. Second problem relates to the dead donor rule, right? This is a core central principle of organ donation transplantation ethics. And a corollary of the dead donor rule, right, is that so long as the individual's still alive, we're going to focus on the patient, and we're really not going to focus on the organ until after the determination of death, right? And another corollary is that we have separate sets of clinicians. The treatment team focuses on the individual while they're still alive, and the transplant team doesn't really encounter the patient until after the determination of death. This is a pretty bright, clear, sharp line, and in the rare occasions when that gets crossed, so for example, when transplant surgeons get involved with the patient before the determination of death, that creates a lot of controversy. So when it comes to PMI, I'll just use the PMI term since that's what Matt used, it illustrates the fact that this line is far more permeable, right, than the dead donor rule seems to portray it. Right? Ideally, the stages would be separate, like a really good tiramisu where you have the mascarpone cheese and then the espresso-soaked ladyfingers. But the layers, in fact, are overlapping. And clinicians are sometimes pulled in opposite directions because you have a single person who is both donor and patient. And clinicians can have the very conflict of interest that the dead donor rule aims to prevent. And then the third problem, and the one that I'm going to focus on, as did Matt, is consent. So again, while the individual's still alive, they're still a patient. While they're still a patient, we owe them treatment duties. And one of those is that you really can't do anything to a patient without consent, right? In the CMPA guide for Canadian physicians on consent, it warns you will be liable in assault and battery if you do something when you had no consent to do that. Now, there may be one exception to that rule, and that might be the apnea test. You know, this is the final confirmatory test for the determination of death on neurological criteria. Let me give you just a quick case from the United States. This is a case from Montana. This little boy drowned. Clinicians did the bedside exams, think that he's probably dead. They want to do the apnea test to confirm, but mom says no. So this case goes to court, and the question is, mom won't give us consent, but do we need mom's consent? Do we need consent to do an apnea test? And the court said, yes, you do. The mother has sole authority to make medical decisions, including brain functionality exams. But there's a real split on this in the United States. Other jurisdictions said, no, you don't need consent. So Virginia and Nevada, New York, Georgia, and Texas all said no. But the apnea test is sort of unique because it's not solely for organ procurement. It's also, we need that information to know what we're going to do for this patient in a treatment context. Are we going to keep them in the ICU? Are we going to continue mechanical ventilation? And that is not true of other PMI, and therefore they more clearly are going to need consent, as Matt said. Where are we going to get that consent from? Ideally, it would be first-person consent from the person themselves, right? Now, when people sign up to be a donor, does that also include or entail consent to pre-mortem interventions? Probably not. and therefore it would fall outside the scope. The authorization for PMI would not fall within the scope of the consent to donate. And I think I just want to illustrate that fact by just looking at the literature that's used with prospective donors. They suggest strongly that there will be only post-mortem interventions. So this is from Alberta, right? That they suggest once the person is confirmed dead, then we may do stuff. This is from a Toronto hospital system, right? The possibility of donation is considered only when brain death has been declared. Of course, it's considered before that. And it's not just a lack of openness and transparency that there will be pre-mortem interventions, but a lot of this really borders on affirmative misrepresentation. Because this suggesting a lot of this literature suggests there will be zero pre-mortem interventions. So almost all these websites and brochures and pamphlets have a section about donation myths. And the top myth everywhere around the world is, if I'm admitted to the hospital and the doctors find out I'm an organ donor, they won't try as hard to save my life. And I just want to look at how different organ procurement organizations respond to that myth. This is Donate Life California. That was the myth. Here's the fact. Fact, the doctors working to save your life have nothing to do with donation or transplantation. But of course, that's just false because they are administering pre-mortem interventions. Legacy of Life, Hawaii. Doctors and nurses involved in your care are not involved in transplantation. And Saskatchewan, right? The medical professionals who care for you before death are not the same ones involved in recovery or transplantation. The Northwest Territories, your choice to become a donor does not affect the quality of life-saving medical care you receive. This is the government agency involved that oversees transplantation in the United States. When you're sick or injured and admitted to a hospital, the one and only priority is to save your life. All right, so it's clear that a consent to donate does not encompass or entail a consent to pre-mortem interventions. So we don't get first-person consent, but we should, for at least three reasons. One is it's always best to get things directly from the horse's mouth, right? We prefer to hear from the patient herself, right? We don't want second-best substitutes unless that's really necessary. That's sort of the whole point of advanced care planning is to elicit so we can hear the voice of the patient herself. Second, it's just faster, right? If we need to get surrogate consent, we need to identify the surrogate, locate the surrogate, reach the surrogate, right? If we already have first-person consent, we don't need to do any of that. And then third, if we really care about patient preferences and values, it's just more accurate to get this directly from the patient herself. Surrogates are supposed to step into the shoes of the patient, right, and do what they would have done. But basically, all of the evidence on surrogate decision-making shows that they're wildly inaccurate in terms of making the same decision that the patient would have made for herself. So we don't get direction from the patient herself, so we need to get surrogate consent. And now, again, that's less respectful of the patient, it's slower, and it's often inaccurate. But there are 4 more problems with surrogate consent. And they all basically are captured by this, which is the surrogate is just constrained in their ability to give consent. And there's 4, and these are just the ways in which the surrogate is constrained. One is they're limited by the statute, they're limited by the law, right? In a number of Australian jurisdictions, the law literally did not allow surrogates to consent to all or some PMIs. Some of those jurisdictions just changed those laws. Scotland just changed its law, and it says that pre-death procedures, that's the term they use instead of PMI, pre-death procedures may only be carried out if that procedure is on the type A list or the type B list. But there's a lot of PMI that are neither type A nor type B, which means they're not allowed. So the statute in many jurisdictions prohibits PMI even with surrogate consent. The surrogate's not allowed to give consent. Second, the surrogate's limited by the advance directive. So many people are going to have advance directives that say no CPR, no mechanical ventilation, no intubation. the surrogate almost always lacks authority to say yes when the advance directive says no. Both the statutes and the forms and documents in almost every jurisdiction require that the agent follow the express instructions on the advance directive. And then the surrogate's also limited by best interests, right? Surrogates are supposed to make decisions in the patient's best interest. And we know that when they fail to do that here in Ontario, they can be fired by the Consent and Capacity Board. In the UK, they can be fired by the Court of Protection. Well, when it comes to non-therapeutic pre-mortem interventions, the very term non-therapeutic sort of illustrates the fact that these are interventions of zero benefit to the patient. Nevertheless, as Matt illustrated, they still pose a positive risk of harm, right? So these come out really poorly on a traditional best interest analysis because it's all harm, no benefit, right? So the scale's pretty lopsided. Now, we can say that the pre-mortem interventions promotes the patient's non-clinical interest in being a donor, but it's really unclear how that weighs or trades off against those physical risks of harm. And then finally, the surrogate is sometimes limited by conflict. This patient who was in a bad car accident in Australia, her case went to court last year. And the problem was, while she was still alive, her boyfriend, who's her healthcare agent, was in charge of making healthcare decisions. But in terms of organ donation, that was left to the next of kin, who was her father. And while the father was prepared and wanted to donate on her behalf, the boyfriend would not authorize any pre-mortem non-therapeutic interventions, which would be necessary for the donation to be successful. So a lot of pre-mortem non-therapeutic interventions are not authorized for a number of reasons, and that is impairing transplant outcomes around the world. I think that Scotland offers us a few tips or strategies or model forward. One is they do break up the PMIs into different risk stratifications. So high, moderate, minimal, right? So minimal PMIs might be taking blood and urine samples. Moderate might be a biopsy or bronchoscopy. And high risks would be, as Matt mentioned, heparin, femoral cannulation, mechanical ventilation. Well, in Scotland, minimal PMIs are implied by the consent to donate. So if you've consented to donate, you've thereby automatically consented to minimal PMIs. Moderate, you do need to get separate specific consent from the patient or surrogate, but still the high ones are still not allowed. But they should be, and I think it would be perfectly ethically and legally appropriate if you had first person consent. That would be respectful of the patient. It would allow us to deploy more PMIs, and that would allow us to get more and better organs. And it's possible to do this, right? We already, in many forms for donation, allow the patient to choose organ by organ, tissue by tissue, and purpose by purpose. It wouldn't be unduly cumbersome to add another section to say, well, do you authorize PMI? Which PMI? And frankly, the state of California recently revised its advance directive document to allow just that. So anyway, the bottom line is I think we should really try to push for first person consent for pre-mortem non-therapeutic interventions. Thank you.
Thank you so much, Thaddeus. I see the chat in the Q&A is getting fiercely active, and we have one last speaker. So we welcome Dale Gardiner, that everybody knows, from the National Clinical Lead of Organ Donation at Nottingham University Hospitals in UK. And Dale is going to talk about non-therapeutic intensive care in practice, what we should do.
Thanks. Thank you, Melanie, and thank you to the organisers. It's my pleasure to join you live from the UK for this session. You just heard two fantastic speakers and outlining some of the complexities. Well, I'm a humble intensivist. I look after adult intensive care patients in the UK. And I just want to try to take that theory and put it into some practice for you. Before I begin, if you're wondering what the butterfly is behind me, it's our donor memorial butterfly that's actually in our national arboretum in the UK. Come and visit it one day when we're allowed. So we look at all these frameworks of practice, and this is just the UK's framework. It is massive. We have so much codes of practice, law, guidances, but who's actually read them all? Well, I have, and they're still quite complicated, even if you actually have read all the codes of practice and everything. And I wondered, how do I put this into a way that we can sort of bring it together, the law, the ethics, how does it interplay? Well, if I was a cow, the law would tell me what paddock I can be in, what paddock, this paddock, not that paddock. But ethics and professional guidance, they tell me what grass I can eat. So the law is quite broad. It just puts us into a spot where we can sort of graze around and make decisions. But when you've got a patient in front of you, what you should do, you know what you can do and what you can't do, but what you should do is can be quite difficult. And for me, practically, the donation law is just a starting place for clinical decision making. And what it means for non-therapeutic intensive care for organ donation, I think we've got three choices to make it really simple. One is the man with the spanner is keep going with your care, intensive care. One is on the concept of organ donation. Yep, I agree. Organ donation's what I or if you're the surrogate, what they would have wanted. And implicit in that is because we're talking about deceased organ donation today, is when to stop. So there's three sort of choices. And being a simple sort of person, I can imagine that my patient comes into the emergency department and then I get a phone call as the intensive care doctor. And then I have to make a decision. Is this patient going to get intensive care? So we can try to make them better. This would be how it would work. And then at some point in this sad story we're telling, I would have to talk to the family and we'd have to agree together that we should stop the treatment. And in amongst that, we step forward and they say, yes, donation is something that's very important to me. And in a simple world, that's exactly as we would hope. It would just follow that. But life is not simple and never has been. We know that actually we can actually make this decision that they're not going to survive and that we should think about donation from the emergency department. That can be certainly possible as well. We're well aware, even in fields outside of donation, that parallel planning in pediatric care, often you're treating a child on a pediatric intensive care, even as you are parallel thinking of what are you going to do if end-of-life care becomes the option. And in fact, that's good practice because sometimes if you put things in series, all you do is cause delays. And sometimes parallel planning is the right thing. And for donation, the referral, as you heard from, especially from Thaddeus, the referral to the donation services often comes at the time you make that, you know, they're very high risk of dying, when to make that decision. So what I'd like to do, and really to open up our discussion in the panel discussion coming up, is give you three case examples to run through. A patient presenting with a devastating brain injury, typical pre-mortem interventions, which Matt outlined, and then the concept of non-therapeutic interventions, even in non-donation after circulatory death cases, the neurological death cases. Okay, patient presenting with a devastating brain injury. So this is, for a devastating brain injury, quick definition, it's a neurological condition with an immediate threat to life. You think it's incompatible with good functional recovery and you're thinking about early limitation or withdrawal of treatment. Well, that sounds okay. You're in the emergency department, you found that diagnosis, you don't think they're going to survive. Let's move on to donation and considering donation. And certainly that's what one of the protocols from Spain suggests, that at that stage you should have an interview with the family. And obviously you haven't confirmed death at this point, but you should talk to them about your plan to admit to intensive care to provide non-therapeutic intensive care for organ donation. And that's what happens in Spain. One of the problems that can happen, and what we've seen in the UK, just extremely rarely, but enough that it sort of made us to rethink, is this sort of case. 28-year-old unsurvivable brain injury. This is from the notes. For consideration of organ donation, the patient recovers. And so I've said for a number of years that donation saves lives, sometimes the life of the donor. By slowing down the process of stopping treatment, you've been sometimes surprised that patients have done better than you expected. And for that reason, in the US and in the UK, we've got what's to call devastating brain injury protocols, because you can only potentially at that time in the emergency department perceive that they're actually going to have a bad outcome. You don't know it for sure, and they recommend a mission to intensive care for more observation. So what that is to imply is you come to intensive care for more care. And someone said, isn't this a Trojan horse? Aren't you really just pretending you're admitting them for intensive care, that actually what you're really doing is you're admitting them for organ donation, so it's intensive care for organ donation in all but name? I don't think that's actually true. There is a nuanced difference in that the DBI protocols, donation may become the goal, but it's not the a priori goal from admission. Actually, the a priori is to actually slow down the decision making to see if there's a chance of recovery. I wouldn't like to say at this stage that one is wrong, like what they're doing in Spain, or that we in the UK and the USA without those sort of guidance is 100% right. I don't think it's as clear as that. And this is my practical advice for this topic of devastating brain injury, this example. I feel it all can be legitimate, but the mistake I see most often is that the clinician, and it's usually the senior clinician's fault, is they're not clear to the family what they're thinking, or they're not clear to the team around them, and they're not even clear to themselves what the reason and the thinking is behind their decision to admit to intensive care. Because if it's for intensive care to see if they can get better and prognosticate, but you still think it's a bad outcome, likely, say it. If you think you're admitting them to intensive care for withdrawal of life-sustaining treatment and it's just a prolonged time to say goodbye for the family, say it. If you think you're coming to intensive care and your primary purpose is for donation, say it. And I think if you're clear, no matter what jurisdiction you work in, that helps enormous way to give you a practical suggestion. Okay, what about typical pre-mortem interventions in donation after circulatory death? And we're talking about the controlled donation that you heard Matt outline. So, this seems to be a lovely little pathway where you make the decision and you move on. And both Matt and Thaddeus talked about the different levels and degrees of those interventions. And I won't go through them in detail, but you can see there's an enormous lot. And so I might actually disagree a little bit with Thaddeus, because if you were faced as someone in the public and you had to choose which of them you'd like to do, well, it could be quite difficult to actually decide, because a lot of them need further explanation, which can be complicated even for a lecture point of view. Where there is a cultural difference, you can see that actually where the UK, Canada, and Spain and USA, just to choose 4 examples, fits on that as of what's allowed, you can see that there is cultural differences, not just legal differences on what you potentially do. What grass we can eat is still applicable. I've left at the bottom, you may notice, I've left you a science fiction example just to really highlight how complicated this could be when you really open the genie and it let out all the different PMIs that you could imagine or think of for the future. And legislating for that can be really difficult. So Thaddeus said quite rightly, we should always act in the patient's best interests. And I think it's still a useful term. In my simple head, it means do what's best for the donor, do what's best for the patient in the terms of talking about donation. One of the challenges can be is who decides this, and this is where some of the controversy is. And I know some people have looked to the UK and been concerned by our best interest court of protection decisions. And the controversy isn't so much about best interest as a concept. The controversy often is who decides what is in the best interest. But in one way, the law in the UK is leading ahead of clinical development. I used to think best interest when I was trained was all about physical best interest, clinical things. And I learned it can include the values, wishes, and beliefs of the patient. The law taught me that. And the law in the UK is also advancing. And one of the legal cases that's come up is the concept of best interest is not restricted to the patient's self-interest, and altruistic sentiments and concern for others can be best interest. And nor is it actually necessary the patient to ever be aware of that, whose wishes were actually carried out. And very interesting, and especially for our topic we're talking about, is best interests do not cease at the moment of death. Both all those legal cases have actually got nothing to do with deceased donation or donation at all. They are just general cases coming towards the court. I think they are leading the way, because in my own practice, when someone's died, I don't suddenly not talk to the family, not care, and not with my care of the body. The nurses are still very careful. They still give care. I still do bereavement meetings afterwards. My care continues, and I think the concept of best interests going on is probably quite a powerful one for our donation and transplant community. So my practical advice, how do we act in someone's best interests? I think make individualized decisions. I sometimes get worried if we just bunch, this is what you got to do in this donor case. Yeah, but what about what they want and the patient wants? And, well, you're allowed to do it. You should just do it. Well, but in this circumstance, see that crying family there? They're really suffering here. I feel like we should make individuals. We should have the scope to do what we best is to actually come and work with the families and with the trying to respect the patient. That's what we should do. We always need to carry out a balance between the harms and the benefits. Sometimes, and this will sway depending on the circumstances, and I therefore don't like recipes of this is what you do. You've got this problem, you do that. And I like to let the strength of the donor's willingness to donate be the determinant. Not, how strongly do you think they would support donation occurring? If it's someone like me or Matt or Thaddeus, it might be quite a lot. Go for it. Do all the PMIs you can, and as Matt said. But otherwise, it may be less so, and I think that's very important. The final example to get us going in our discussions is the concept of non-therapeutic interventions in when you actually have to yet to determine neurological death. And the thing is, what happens is to do brain death testing, it doesn't just come out of nowhere. You actually have to plan for it. You have to communicate it. You have to set it up. You may even have to stabilize the patient to get there. Now, it's not normally the case that we were sort of intensive care at that moment and we're full on intensive care and then we're planning donation and death testing. It's more like you've come to the point where we're almost, we think that they probably died, and we're in that sort of period there on our little graph there. And the question is, and how much intervention is allowed, how much non-therapeutic intervention to get that diagnosis, to make that confirmation, and then to allow donation after brain death to occur? Well, you could think about stabilizing for testing. These are unstable patients because their brains aren't working. Elective ventilation is a case where you could, if they come into the emergency department, and Matt spoke about that case, and it's common in many countries, but still not in the UK. In some countries, but not the UK, if someone has skull fractures and they potentially may bandage the brain, and then they're more likely to progress to brain death, which they would claim is a more natural way, or was going to happen anyway. And sometimes people have drains in their brain to try to allow for treatment, and they sort of, as they're heading towards death, removing that. These are some of the controversies that can occur. Of course, you could begin exploring donation before you've confirmed death. Investigations. What about medications? We normally give steroids after death and after consent for donation to reduce the inflammation for the transplant recipient. What about giving it before? So what's my practice advice? I think make your goal be the determination of death in this case. Focus on that. In many countries, including the UK, we put a lot of time and education into helping doctors confirm death, not just for donation, not at all, because the diagnosis of death using neurological criteria, NDD, brain death, whichever term you want, is helpful in itself because it gives surety, and it's a diagnosis, and it's very useful. The next thing I'd say is be clear again to the family, your team, and yourself. What are you doing? Why are you trying to progress? What are you trying to achieve? Because if you're thinking it's for donation, I think you should say that at the time. So coming back for a second as we come to a conclusion, here we are, non-therapeutic intensive care for organ donation. I'd really love it if this was simple, and as we've outlined with Thaddeus outlining, a progress, can we achieve it? Well, I did try to achieve it with some colleagues. We contemplated a 4-stage pathway, and we called it intensive care for organ preservation. And I think when someone comes into the emergency department, they're generally unstable. And our primary job as doctors, clinicians, is to reverse the instability and probably admit the patient to ICU to actually neuroprognosticate. It's a difficult time for anyone. You can't talk to families then. Try to reverse the instability, come to intensive care. When you get to intensive care, often you get things a bit more stable for that. And in that time, while you're thinking, our goal has to be the best neurological outcome for the patient. Then you may enter a period when you know things aren't going to end well. And in that period, it's not necessarily a moment. It's actually a progress. As it takes a number of steps and investigations and discussions with families, but you establish futility. And that should be based solely on the conviction that everything that should be done has been done in accordance to the wishes of the patient. And then finally, you move to finality, and that's where you provide finality. And that's where the therapeutic goal shifts to focus on end-of-life care. And so in summary, 4 little stages. I try as much as I can in practice to be clear in myself which stage am I in, so that I don't morph and jump between them. Because as a leader of my intensive care, when I'm on the shop floor, when I'm talking to families, I'm the one who has to make it clear to the family, to the team, but it begins with myself. What am I doing? Is this non-therapeutic intensive care for organ donation? Actually, is it intensive care? It's my job to be clear, and that's good practical advice. Thank you for listening.
Thank you so much, Dale. And actually, Matt and Thaddeus, you can turn on your camera. I think it's going to be a very lively discussion. Be ready. So your presentation set the tone perfectly. I'm going to try as a moderator, because there's so many questions, to ask questions from different perspectives. So the first one I'm going to take is from Linda Powell, a caregiver. And the question is, how can the public become best informed about conflict between consent and desire to donate and non-life-saving intervention, and how to resolve? So maybe Matt and Thaddeus, Dale, everybody.
Yeah. I think actually I'll take a first stab, and then I'll kick it over to Thaddeus, because Thaddeus, I thought you brought up some great points in your talk about, you know, reaching out to the public, and seeking out first person consent. I think, Dale, you brought up one of the key points, that consent for donation and PMIs is just an inherently weird thing compared to a lot of other consent. You know, when we were on a call the other day, I mentioned, you know, I'm not going to give consent today to a surgeon that if I ever show up with right-sided abdominal pain, just take me to the OR and take out my appendix, no questions asked. You know, like, even if it, you know, might happen 15 years from now, it's an unusual thing. And then the specifics. So I guess how Thaddeus, do you deal with that? That even if we were to ask people about PMIs in general, we wouldn't be able to ask for about the PMIs, the specific PMIs in detail, and how they relate to your specific medical situation, say at some point in the future. How would you address those issues, which there have kind of been a few in the text box around this?
Yeah, and I think Dale pushed me on that same point, right? Which is it's hard. I mean, let's start easy, right? We could do better than we do right now, right? So you could at least, because you're still going to seek consent from the surrogate, so you could provide some guidance to the surrogate. Right? And that's sort of not unusual for all advanced care planning, where generally the patient expresses some broad and general goals of care, but the specific decision, because it's always going to be clinically specific, then falls to the surrogate, right? But the advanced directive provides some guidance. So we could at least say high risk, low risk, right? Are you okay with, you know, more invasive PMI if it's necessary to make your organ donation successful? Yes or no, right? So without getting into all the granular level detail. So we could do better than we do now, right? I think one of the questions was about education. As far as I could tell, we don't educate that about PMIs. Frankly, as I tried to illustrate, if we do anything, it looks like we're kind of hiding it, right? We're disguising the fact that it even happens. Now, and that's a tough public policy issue, because some would say, well, that's important because if you tell people they're going to be PMIs, it's going to freak people out and then they won't want to participate in organ donation. But the other side, of course, says, hey, if you're not open and transparent and honest, then you're going to lose the public trust. And that's going to impair organ donation. I don't know which one is right. I'll just share that we're having a very similar debate in the United States about brain death itself. General consensus that the way clinicians determine brain death in the United States correlates neither to legal death nor to biological death. And then the question is, do we fix that and make them line them back up, or do we just kind of hope, because that would scare people, or do we just continue to ignore it and hope it just goes away? And again, I don't know the right answer to either of those questions, but I do think we could obtain some guidance from the donor, from the patient herself, without getting into all the granular detail.
I agree with Thaddeus. I think there is something more we could do. I'd love to have a system. I think he makes a great point and challenge to us organ donation organisations that the information we should provide, it should be like layered. You should be able to dig deeper. You know, you want to know more, click here. Do you want to know more, click here. And potentially you can work your way down from it. You're not necessarily saying, look, here's ECMO cannulation, here's this one all at the front. And you're just saying, well, I just wanted to sign up for the organ donor register. But we should be allowing people to do it. And I will add that Scotland has done, a pretty amazing job they brought in presumed consent, deemed authorization, it's called there, and they've written out to every household in Scotland and talked about these pre-death procedures. And they just use gentle words that I'll just read them for a second for the audience. As part of the donation process, certain routine medical tests and procedures may be carried out in intensive care. And they're very simple words, and they do explain them in more detail about x-rays and things. And I think so it can be done. And I think that we sometimes are fearful of the public, as Thaddeus said, and we shouldn't be. We should be sort of definitely more, make it available.
I'm going to take a moderator privilege to add something. What do you think about partnering with the patient, donor, family, and the public to kind of try to understand a little bit where we can go, and particularly in certain jurisdiction, as you highlighted that there's some cultural, a component that needs to be addressed. Maybe Dale.
I think so. We've we really value our particularly our donor family network, and that's why I've got their memorial behind me. I think they can be an enormous resource. I think it's important we work with our donor families, but also potentially like other families who actually didn't go through donation, because otherwise you want both sort of perspectives. Yeah. And I think they have a huge role in reading the material we produce, making sure it's understandable, making sure it's answering the questions. And, that's what, lay involvement is essential for pretty well everything we're doing. And we've benefited, we benefit from that because we feel reassured. And that, they're mainly, for half the time, I feel like they help us so much, and they make us feel that we actually are listening, and it's really helpful.
Thanks, Dale. Excellent. Maybe
I think,
go ahead, Thaddeus.
Sorry. Just real quick. I think it's worth reemphasizing something that Matt pointed out from his systematic review, which is I think what he said is there's universal support for the idea that we do need consent. So nobody thinks we should just we should just administer non-therapeutic pre-mortem interventions, right? So I guess in a sense, I don't think we're doing anything unethical or illegal. It's just that we're actually not able to get consent a lot of the time. So my point was that, right, is not that we need to really change what we're doing in order to better satisfy legal rules or ethical norms, but that we could, like, so for example, the case that Dale just gave from Scotland, there may be people who are really gung-ho, really patriotic about organ donation. They are unable in Scotland to check a box to say, hey, do whatever you need to do to get my organ, because Scotland limits you to only the preset procedures.
That's a great point, Thaddeus. And I think it's like we need to have everybody agrees there needs to be consent, but then you need to have policy and procedures and definitions around what makes that consent valid in your jurisdiction. I think that's really the one of the key considerations there.
I can also highlight the cultural differences, as you've seen the difference between the countries. What some countries think is just completely acceptable, and they're not even sure why it's even being discussed. And other countries going, "You're doing what?" And I think there's an international variation in that, and you have to be culturally sensitive. But also, culture has shifted. The things that are now considered standard donation procedures in the UK 15 years ago were quite frightening to all us clinicians that we would ever go there. But as we sort of realize and actually give the emphasis on the donor and respecting their want to donate, it's actually changed our culture.
Absolutely. So maybe we're going to switch gear and look from another perspective. So it's anonymous, but as a donor coordinator, the necessity of PMIs can be difficult to navigate at the bedside from the ethical and moral nursing perspective. balancing the patient comfort versus the drive to optimize donation and complete testing necessary to ensure safety of transplanted organ and saving as many lives as possible. At times, it feels necessary to have a case-by-case decision. I think some of you referred to it, on certain intervention, and not a blanket what is required for proper assessment on organ interest by transplant. So one question I think that stems from that: who's implicated, who's taking the decision, and I think this perspective from the donor coordinator is quite enlightening.
Yeah, and I'll take a first pass at that, and I think there is implicit in that question is the idea that often, I know as someone who receives these calls from coordinators in terms of how to navigate tricky situations, there's sometimes variability even in terms of who is the transplanter who's going to be recovering the organs, in terms of how much emphasis they'll put on a particular procedure. And that just comes from the fact that there isn't good evidence. And some of the other questions in the text box have pointed that out, that a resounding yes, we need more evidence and to inform this debate and have a realistic look at what the risks and benefits actually are. Because what it does lead to that type of situation that you're describing, where you have a patient, and on one day you have the surgeon saying, I absolutely need heparin for this patient, and then 2 weeks later you have a very similar situation, but another surgeon on who's like, we don't really need it that badly, and that can be quite confusing for the bedside staff, and how the information is then presented to the family. So getting more scientific evidence on how these things actually work is a big deal. And Sunny Donani was just telling me how much time he has and how he's looking forward to running those studies. It's crazy.
So if I follow on, this is a huge challenge is to know that you're doing the right thing, because that's what I think this question is. How do you know you're doing the right thing? Because that's what we're all here for, is to do that. There's no simple answer, but I think when in doubt, go back to the family. Although, as Thaddeus said, they're not perfect as surrogates, but in many ways also we have a duty of care to them, and they're going to be the ones who remember. So we need to sort of be mindful of our need to do what the patient wanted as well, but at the same time mindful of them. And they probably the best way to judge how far pre-mortem interventions and these interventions, non-therapeutic intensive care, can go. And that's my default. When in trouble, when unsure, go back to the family, because only they can really tell you the strength of someone's desire to donate. If they've spoken about it before, that's been important, they have a relative, all these make it much more powerful.
I think this illustrates that we unfortunately have a lot of ignorance on both sides of the equation, both in terms of, are these things even effective, and also what exactly are the patient preferences about them. So it's really hard to do any kind of best interest analysis when you don't know either of the two sides of the scale. But I guess one takeaway I take from that is the lack of, and I think it was Dale illustrated the fact, we don't even know how effective heparin is. It may not be that effective. Then the fact that we're not getting surrogate consent in some jurisdictions maybe not that much of a tragedy, because we may not be losing anything, because the thing that we're not able to get authorization for may not have even been that effective in any case. I think so. The real challenge, if we're really going to, the need to push forward to clarify the rules for consent may not even exist right now until we have good clinical evidence that certain PMIs are effective, and we're not able to do them. Then that would, of course, make a strong case for rethinking consent. But since we don't actually know that we're missing anything in terms of clinical effectiveness, maybe the case for revising consent rules isn't all that strong right now.
Yeah, I think your point is well taken. Dale, you were about to say something, sorry.
Only that I was going to highlight the good news that's coming. Martin leading very much his peri-mortem interventions work and his publication. In the UK, we're working on a donation actions framework, very similar sort of concept. And in that one, we're going to divide up all these potential interventions as very likely in the patient's best interest, likely, and work our way down to unlikely to do not do this. And I think although there's problems with that, I feel like we're beginning this process of engaging with the wider community and the public on this discussion. So I see hope for the future.
I was going to, because there's a lot of question and reference to research and getting evidence, and I think you're all underlying this. What would be your priority, the first thing you would do, the first trial, the first study that you would do? What would be your primary study that you would do?
I'll jump in first because many of you may know or may not know that actually heparin is not allowed in the United Kingdom pre-mortem. It's common in Canada, it's common in the United States, common in some parts of Australia, but not in New South Wales. So, we've got this variation around the world. We, of course, have been doing donation after circulatory death for nearly 15, 20 years with excellent outcomes without using heparin. So, science, do we even need it? And I think just answering that question could be very powerful. But randomized controlled trials of an intervention before you've actually the patient's died that are non-therapeutic to them, very complicated. And so that's one of the challenges for this research.
Absolutely. Matt, Thaddeus, you would jump in?
I'll leave that. That sounds like a clinical question. I'll leave it to the clinicians.
No, and I agree with Dale. I mean, these are scientific questions that need to be addressed. It's just devoting the limited resources we have in donation research towards answering those questions. But yeah, I do think it's something that would provide a lot more clarity.
And as the state of because there's a lot of question about education, how would you approach that part, even as we are with the lack of evidence? Is there something more that we could do in terms of education, public education?
So, I agree with some of the comments that were made earlier, that in general, I tend to think trust your public. You don't have to trust them by, like Dale said, we don't have to give the schematic that I put up around what femoral cannulation looks on the front page of the Transplant Québec website. Okay. But I think having, I liked Dale's model of having the potential to arrive at least a description of some common PMIs, what at least our estimates of their risks and benefits would be. And so that people do have an understanding. I think it is unfair how things are structured now. And I think there are some fair criticisms that were brought up by several of the articles in our review, that the way donation registry is presented now in whatever form you get it, either it's on a website or anywhere else, it is almost a universal good with no discussion of the cost. Families are often surprised, oh, wait a minute, if I'm going to be a donor, even just the idea in brain death donation, that they're going to have to be, their loved one is going to be in the hospital for 3 more days. Like, that is, we all know that. And anybody who's in donation knows that it's going to be at least 24, if not 72 hours more of ICU. Why isn't that communicated at the time that people register? And so PMIs could fall into that as well. And so I think, trusting because if we don't inform them, somebody else will. And that information will be given, and often in a distorted form, often exaggerated in ways that it put too much emphasis on perceived risk and not enough emphasis on perceived benefit. And so I think controlling that narrative is something that we should all, who are in the kind of policy and public education sphere, give some thought to.
Excellent, thanks. I'll jump to a question from, I lost it, sorry. From Jed, sorry, I lost your question, Jed. Oh man, I cannot put you on the list, right? I think it was about, okay, I'm gonna jump in.
I think it was largely addressed.
Oh, yeah.
It was about public education.
Okay, excellent.
I'll just say I agree 100% with the comments that Matt just made. I'm not like a communication specialist. I don't know exactly how to do it, but I agree that we should do it. We should do more than we do. I was really shocked, right? I had a ton more examples, right, of websites from around the world where, it's not just that we're not telling people that there will be PMIs. We're actually sort of saying there won't be any PMIs. Nothing will happen. Nothing will be different until after the determination of death, which is just false, right? So I was just sort of shocked at the pervasiveness of, it's sort of anti-education, right? It's the opposite of being open and transparent. You're actually almost being secretive or deceptive about how it really works.
Was that underlined by any families that you were that you were encountering? Was that reported really when in your practice, that type of difference? Like, I didn't know, it wasn't like that, and like the question of trust.
If I answer clinically, I mean, I think one of the interesting things that we talk about registrations is organ donation registration overrules by families. And they're very complicated. When you're in the United States with first person consent, they're sometimes not allowed. And in other countries, they're more permissive. It's a challenge for families. And one of the claims that families often make is, if my relative knew what the actual circumstances were coming out now, they would not have agreed. And that's very difficult, because that, are they actually the voice of, are they misrepresenting? Are they like Thaddeus's 63% chance that they're actually right with what they would say? Or do they know better? And actually, if the relative could wake up suddenly and magically sort of communicate, they will go, well, look at my family, look how distraught they were. You should stop now. And I think that's sort of one of the issues. And partly why for me, and I said it right at the beginning of my talk, it's the consent for donation for me is a starting point for a discussion with the family. It's not the end. For me, donation consent is not binary. It's actually it starts me down a direction, and it's that's my default position, but it's not binary, and I'm always looking for individualizing that for that patient.
I think that sounds like a really great approach. So I see the time is flying. Maybe I'll give the chance to Matt, Thaddeus, and Dale to give final thoughts as we're closing this really interesting session.
I'm going to close with, actually, I'll address one other question that I see from Wendy here in Montreal around, I think as a policy perspective, this is another example. The question is around checking donor registries for someone who arrives with a devastating brain injury. And I think that's an example of, I like Dale's framing of, the law needs to allow it. And then I think then your ODO and your hospitals need to make it into policy, because in the same way that, of course, we would consider someone's advance directive on considering whether or not to intubate that patient, we need to consider their express consent to donate. And yeah, that might cause tension if they have, as I mentioned in my talk, that might cause tension if both of those things are true, but that's what you work through with the SDM, assuming they're going to act in their best interest. But the policies and the law need to align so that the clinicians or the coordinators have expressed permission to verify that consent. But anyway, so that's the last point I wanted to make. And then, great job, guys. I really appreciated your talks. I just wanted to say that you guys are great presenters, and I appreciated being on this panel with you.
Thaddeus, some last thoughts?
Yeah, so I hope maybe we could loop back to this. I saw a couple questions about presumed consent jurisdictions, and I don't think that things would work different in a presumed consent jurisdiction like Nova Scotia, because as Matt illustrated, we're basically going to get separate specific consent anyway, whether it's an opt-out jurisdiction or an opt-in jurisdiction. But I will be interested in the later panel, right? Because it's a similar issue, which is, well, the person didn't opt out, therefore they obviously are okay with being a donor, and if it's not clear that they understood either how they could opt out or that they needed to opt out. And I think we have similar parallel questions here with the PMI. So it'd be interesting to see those sorts of implicit consent issues in the later panel. But yeah, I also think it was great working with Matt and Dale. Thank you.
My final comment as well is a fantastic event, and we'll look back very fondly. I think we've started something here. But actually, I learned something very important a number of years back when we were allowed to travel, and I was in Canada, and I heard someone from the Canadian Medical Association talking about disclosures. Like at the beginning of our talks, you saw roles that Thaddeus and Matt and I have, and you saw our disclosures. But all that pressure, he said, was on you. as the audience to actually work out what does that mean, how important is it. And so bombarding public with information doesn't always work. What we need to do, and this is what I took from that meeting, is we need to build institutional trustworthiness. We need to be worthy of the public's trust. And that's what I think we need to build and work together as really an international community. This is beyond one nation, to actually build trustworthiness in our donation process. And I think we have, but we need to maintain it and never let up. So thank you for the opportunity. It's been an absolute pleasure. Wish I was there in person.